mediastinal restaging. Is it a valid option for locally advanced non-small cell lung cancer or not? Many clinicians using restaging after induction therapy as a way to select who are the patients who will benefit from surgery after induction chemo or induction chemo radiotherapy, especially for those patients with locally advanced non-small cell lung cancer. So selecting the appropriate treatment strategy for patients with locally advanced non-small cell is of utmost importance to determine the patient outcome, especially the nodal downstaging after induction therapy and local irradiation. Those can better predict the disease-free or overall survival, especially when combined with surgery. However, nodal restaging can be technically difficult. This group of patients usually considered to be those with stage 3A, which is a heterogeneous group that will be discussed later, and it accounts for about a third of the patients with lung cancer. And most of this stage group consists of patients with malignant involvement of mediastinal lymph nodes. So they are, most of them, N2 disease. Although the optimal management of these patients is unclear, there is a common practice between physicians that considering preoperative induction therapy, whether chemo alone or chemo radiotherapy, followed by surgery, believed to be downstage dose group. When we look at the NCCN guidelines and found particularly those heterogeneous group of stage 3A, so maybe those with early T stage, T1 or T2, but N2 disease, or locally advanced in primary tumor stage, T3 or T4 with N1 disease. This highly heterogeneous group has poor 5-year survival rate, about 37 of them with clinical N1, those with T3 or T4, and quarter of those patients with mediastinal nodal disease. So why mediastinal restaging is crucial and important to do it after induction? For tailoring the further treatment strategy, whether definitive radiotherapy or surgery, or another modal treatment like systemic treatment. And more accurate staging will associated with better survival. When we go to the modalities of imaging like CT or PET-CT, they have low sensitivity and not sufficient for accurate staging, which will be discussed in details, and cytological or histological confirmation, whether fine needle aspiration cytology by EVIS or core biopsy by mediastinoscopy, is essential for this restaging. And also patients who are surgically unfit can be considered for multimodal treatment. Survival in patients who has residual metastatic lymph nodes after mediastinal restaging, those have inferior or poor survival, even if they are N0 or N1 after neoadjuvant, especially those with multi-level metastatic lymph nodes. This is a systematic review about cases what underwent restaging after induction therapy for this group of locally advanced non-small cell stage 3A. In this systematic review, they see the false negative rate of each modality for restaging, comparing the different modalities, starting from non-invasive techniques like the CT or PET-CT, and then the invasive procedures. First, they comment about the CT scan and found that few studies evaluate the reliability of CT in mediastinal restaging and give us information about whether these lymph nodes are still pathological or underwent complete pathological response. And results from this systematic review support the general belief that CT is a poor modality for restaging with high false negative rate reaching 40%. When we're talking about PET-CT, there is 10 studies evaluating the PET to determine whether there is downstaging from N2 to N0 or N1, and also the PET has high false negative rate, lower than CT, which is 40%, but still high, reaching 25%, and the false positive about 33%, because PET-CT may give avidity for those who are fibrosed from radiotherapy or have complete pathological response or inflammatory, but still avid, so they are false positive lymph nodes. And one study found that approximately 1 month after the optimal, after induction therapy, whether chemo or radio, this is the optimal time for restaging by PET-CT. So PET is superior to CT in accuracy, but it still has high false negative rate. And this makes us go to the invasive procedures like EVIS or mediastinoscopy. And this is essential to take cytological or histological confirmation of the mediastinal lymph nodes. Those patients with high risk mediastinal involvement after induction can be performed whether by mediastinoscopy, which was the gold standard for mediastinal staging a few years ago, or through minimally invasive techniques, endosonography by EVIS, endobronchial ultrasound, transbronchial needle aspiration, or esophageal ultrasound with FNA. Both modalities have been proposed as initial for mediastinal staging instead of the surgical techniques. When we're talking about EVIS, the use of this technique either alone or in combination with another modality like EOS, this increases the sensitivity and negative predictive value and accuracy than the imaging alone because it takes cytological confirmation of positivity for these lymph nodes, especially when applying the ROSE technique, which is rapid on-site evaluation by presence of cytologist or pathologist at the OR room to confirm that the biopsy taken by the EBUS is conclusive instead of came after a while that it is insufficient material. And also, not just conclusive, but it can diagnose whether it is malignant or sarcoidosis, and this makes the interventional pulmonologist to take further biopsy from the lymph node until the pathologist confirm that there is sufficient material. For this reason, EBUS or EOS becoming more widely available, and the results are better, and their false negative rate now 15% lower than those of imaging modalities. Moreover, these techniques, which are by endosonography, are safe with very low morbidity, low mortality rates, cost-effective, accurate by using the ROSE technique, and rapid, providing diagnostic information in less time with fewer invasive tests. You can reach the diagnosis on a spot at time of the procedure. Here is a picture of the endobronchial ultrasound, convex probe by needle aspiration, or EOS. And here is a picture at the right side of adenocarcinoma confirmed by ROSE technique at same time of evaluation. And it's also real-time ultrasound technique because the pulmonologist or artificial pulmonologist can know which of the lymph nodes by sonar is specific to take a biopsy and whether and others which are not specific. The stations where the EBUS can sample are 2R, 2L, upper paratracheal, lower paratracheal, 4R, 4L, and subcarinal lymph nodes, as well as hilar stations. It can be reached by EBUS 10, 11, and 12, while EOS can reach different stations like 8 and 9, paraesophageal and inferior pulmonary ligament lymph nodes. For sequence of biopsy by the EBUS, it should be in an order by taking biopsy from the healthy side first, which is the contralateral side. So at this picture, if the tumor at the right side, EBUS should be done first from the left side to exclude N3 disease, and then go to the ipsilateral side of the tumor, mediastinal first, upper or lower paratracheal lymph nodes, until reaching the hilar nodes N1, which are level 10 station. So this is the EBUS. Now we'll go to the re-mediastinoscopy, which means that these patients underwent mediastinoscopy before induction and then mediastinoscopy after induction. It has sensitivity reaching 61%, negative predictive value 85, and accuracy, and it's safe in experienced hand, especially by using the video-assisted mediastinoscopy, which can biopsy paratracheal lymph nodes, limited to stations 2 and 4, and subcarinal lymph nodes. However, few institutions are not comfortable with this technique because the results are disappointing from the false negative rate, which may be 25%. Re-mediastinoscopy is a challenging procedure, and it is controversial and difficult due to the presence of fibrosis from the previous mediastinoscopy, adhesions, and tissue necrosis from chemotherapy. This is a picture of the cervical mediastinoscopy and the stations which can be reached, mainly 2R and 2L, upper paratracheal, 4R, 4L on both sides, and subcarinal lymph nodes. Can be done by mediastinoscopy, video-assisted, or operating mediastinoscopy. Chamberlain procedure is another procedure for mediastinal staging, and it is specific for para-aortic and subaortic stations, level 5 and 6, only on the left side. Chamberlain procedure, which is anterior mediastinotomy, has a risk of injury to phrenic or internal mammary, and it is done only for these groups. Also, these groups can be approached by extended cervical mediastinoscopy, EOS, or left VATS. Mediastinal restaging by primary mediastinoscopy. Patients who underwent staging by EBUS and then receive induction chemo, those can do primary mediastinoscopy for the first time after induction. Two studies addressed first-time mediastinoscopy for staging by video-assisted mediastinoscopy. All those patients had mediastinal involvement by FNA using EBUS or EOS, and it has false negative rate, which is the lowest. False negative rate can reach 3% to 15%. So primary mediastinoscopy in restaging performs fairly well, consistent with the performance of primary mediastinoscopy, which can be done before induction therapy, especially with video-assisted mediastinoscopy. However, this requires avoidance of mediastinoscopy in the initial staging before induction treatment. And this is a picture of the video mediastinoscopy. It has high sensitivity, reaching over 90%, and 100% specific, with negative predictive value reaching 93%. This is a schematic review comparing the different modalities which we are talking about regarding the false negative rate of each one. So the first table mentions that CT has false negative rate can reach over 30%, while PET about 25, remediastinoscopy after previous one over 20, EBUS or EOS about 15 or more to 20, while the first or primary mediastinoscopy after induction has the lowest rate of false negative rate. Regarding the sensitivity, the best for EBUS, EOS, or mediastinoscopy, who has the highest sensitivity of mediastinal restaging. The last step, which can be used for restaging by VATS, which allow or can reach all mediastinal lymph nodes, but only unilateral, the same side of the tumor. And it has some advantages, like it is an invasive procedure, need general anesthesia, double lumen endotracheal tube for selective lung ventilation, several VATS ports or maybe uniportal, and chest tube for drainage. However, VATS can add to the mediastinal staging by evaluating the T stage and also can exclude pleural dissemination. So VATS should be concised for specific situations. Patient with AB window lymph node, which cannot be approached by EBUS or EOS, it can be approached by VATS, or excluding pleural dissemination, or assessing also the primary tumor, and it has false negative rate, which can reach 7%. So in summary or take-home message, these methods of restaging are commonly used to select or exclude patients from surgery. In particular, the mediastinal downstaging by CT PET carry false negative rate, which can reach 20 to 30%. EBUS, EOS perform better. Secondary mediastinoscopy difficult due to the adhesions and fibrosis, while primary mediastinoscopy seems to be the most reliable method. Ideally, initial staging should be done by FNA, whether EBUS or EOS, so primary mediastinoscopy can be used for restaging. Thanks for your attention.